Hi, I'm Dr. Michael Mirochna. I'm a board-certified family medicine physician. I work in Valparaiso, Indiana for Porter Hospital at Vail Park Primary Care and Lake Porter Medical Group. I'm going to talk about cholesterol and its role in our health. I'm going to get to cholesterol, but I first want to lay a framework for the discussion. Death. That's an ugly place to start, but frankly, that's what we care about. No one wants to die. We also care about heart attacks and strokes because they can lead to death, and sometimes something almost as bad or even worse than death, a decreased quality of life, also known as QOL. A heart attack or stroke may leave us severely impaired and unable to enjoy life as we would like. Well, we know the risk factors for cardiovascular disease, and these include age, sex, family history, diet, activity or exercise, blood pressure or hypertension, diabetes, smoking, body mass index, and cholesterol. Cholesterol is one of many risk factors. Since we framed the discussion around preventing heart attack, stroke, and death, let's quickly address each of these factors. What do we do for them? Based on age and sex, your doctor may have you take a baby aspirin every day. A common guideline is for men to start taking a baby aspirin at 45 and women at 55. Different doctors may follow different guidelines, so discuss this with your doctor. With family history, we don't do anything specifically, but we do take into consideration when making diagnostic or treatment decisions. For diet, we recommend a healthy diet, obviously, but a good point of emphasis is to have 5 servings of fruits and vegetables per day. This is hard, but not as hard as you might think. For example, a big apple, banana, or orange can be 2 servings. In regards to activity or exercise, we recommend at least 15 minutes a day. Some folks or docs will recommend 150 minutes per week. A 2011 study from Taiwan indicated that 15 minutes per day is the bare necessity for benefit. People were estimated to live 3 years longer if they achieved 15 minutes of activity per day over the 8-year study. This exercise could be as low-key as walking. We screen for and treat high blood pressure and diabetes when we find them. If your blood pressure is greater than 140/90, see a doctor. If your fasting blood sugar is greater than 100, or you have an A1C greater than 6.0, you should also see a doctor. We are constantly screening for tobacco abuse, and we use nicotine replacement therapy such as patches, gum, lozenges, and Nicotrol inhalers, as well as medications such as Wellbutrin, Chantix, and nortriptyline to get people to stop smoking. Body mass index is a ratio between height and weight, so that we can tell the difference between a 300-pound, 10-foot tall person and a 300-pound, 5-foot person. A normal body mass index is 18.5 to 25. 25 to 30 is considered overweight, and greater than 30 is considered obese. Newer indications suggest that a BMI less than 30, while traditionally considered overweight, may still be a healthy weight. And that brings us to cholesterol. Here's a blood vessel when we were born, wide open and no blockages. Blood flows freely here. Over time, blockages called plaque develop. They are made of cholesterol. They grow as we get older, and the reason these plaques are bad is that they can rupture, represented by the star in the picture here. When this happens, a clot develops and blocks blood flow. The heart and brain tissue beyond the clot isn't able to get oxygen, and this causes the heart attack or stroke. We have thought of cholesterol in regards to its breakdown of total cholesterol, triglycerides, or triacylglycerol, good cholesterol, known as high-density lipoprotein, and bad cholesterol, known as low-density lipoprotein. You can remember those for the H for good cholesterol because we want that high, and the L for bad cholesterol because we want that low. Traditionally, we have gold numbers in regards to each category. Total cholesterol, we usually want below 200. Triglycerides, we'd like those below 150. Good cholesterol, we'd like to see that above 40. And bad cholesterol, anywhere from 70 to 160 based on certain risk factors. We use a handful of cholesterol medications to lower cholesterol, and these include statins, which have brand names like Zocor, Lipitor, Crestor, and other medications such as Zetia, niacin, and fibrates. A brand name of a fibrate would be Tricor. These medications will change up your cholesterol numbers in the right direction. We think that they are reducing heart attack, stroke, and death because they are able to change those numbers up. The problem is this picture isn't accurate. It's not correct. We do know that these medications will change our cholesterol numbers in ways that we think are positive, but they are not reducing the numbers of heart attacks, strokes, and deaths. The medication that has been backed strongly by numerous studies in the literature that has actually been shown to not only change your cholesterol numbers, but also to reduce your risk of heart attack, stroke, and death are statins. Let's simplify this side. There's a lot going on here. Statins lower the risk of heart attack, stroke, and death. It's that simple. So how did this happen? We have evidence that a medication improves a clinically relevant outcome, like reducing the rates of heart attacks, strokes, and deaths. And we think that we know the way medicine works, like statins lowering your cholesterol. We then call cholesterol a surrogate marker. It's very expensive to run trials to prove clinically relevant outcomes change during a study. They take a long time, and we need a lot of patients in those studies. It's much cheaper to show that medications change a surrogate marker, as I've demonstrated with the arrow pointing out total cholesterol, triglycerides, good cholesterol, and bad cholesterol. And as I've shown and talked about previously, niacin, Zetia, and fibrates will also change up those cholesterol numbers. When we believe that changing those surrogate markers leads to clinically relevant outcomes, we are making a huge assumption, as pointed out by the arrow in this slide. It turns out, though, that this assumption is wrong. And that's what's happened for fibrates and Zetia. Evidence that came out before statins were around in regards to niacin showed that niacin was actually a fairly decent medication, but the most recent study called AIM High, which included patients that were on statins and had niacin added to their regimen, didn't show that niacin was helpful at all when it was combined with a statin. The fibrate medications weren't helpful in a high-risk population in the Accord study that came out recently as well. Furthermore, Zetia has never been proven to lower clinically relevant outcomes by itself. Clearly, seeing this slide is probably very frustrating for you, and it's also quite confusing. Let me simplify. Again, statins lower the risk of heart attack, stroke, and death. So why are the statins actually working, you might ask? Well, if you remember those plaques we had a few slides ago, we actually think that statins work by a process called plaque stabilization. They make the cholesterol plaques less likely to rupture, which leads to a heart attack and stroke. So getting back to the statins, how do we decide if you need a statin? First, we need to determine your cardiovascular risk. Using a risk calculator or some of the earlier risk factors mentioned, we can calculate your risk. The one I use is the Framingham risk calculator. We take your age, sex, good cholesterol, total cholesterol, systolic blood pressure, which is the number on top, if you're on blood pressure medications, and whether you are a smoker or if you have diabetes. We plug that information into the calculator, and we then get a percentage chance of having a heart attack or stroke over the next 10 years. To put this risk into perspective, 0 to 10% risk is considered low risk, 10 to 20% is intermediate or medium risk, and greater than 20% is considered high risk. This is a ballpark estimate of your risk. It is key to see here, though, if you just randomly punch in some different numbers to see how the risk factors would change for you individually, is that you can have a high risk with either normal or low cholesterol, or you could even have a low risk even if your cholesterol is high. That's a really important factor to remember. So what we do next is take that 10-year risk of a heart attack or stroke, and we subtract 25% of that risk to figure out what your benefit would be from being on a statin medication. Where I get the 25% reduction in your risk, which we would call a 25% relative risk reduction, is from 3 different studies. One being the Jupiter study that came out in 2008 in one of the more popular journals, the New England Journal of Medicine, the Heart Protection Study, which was in the British Medical Journal back in 2002, and another study that was in the British Journal of Clinical Pharmacology back in 2004. So let's take a look at 2 examples so you can see how this works. If your risk was 10% from the calculator, we would then subtract 25% of that risk, which would be 2.5%, and that would give us a yield of 7.5%. That would be the risk for a person who had initially a 10% risk of a heart attack or stroke over 10 years would now become 7.5%. So if your risk is 20%, we would subtract 5% of that risk, and your risk now would be 15% if you took a statin medication. So as you can see from the example, the higher your risk, the higher the benefit is of the statin. What I like about this approach for patients is it allows them to make their own decision about whether they want to be on a medication or not. We call this autonomy. So patients have a large amount of autonomy here. And the reason this is important is because some folks in that first example would think a 2.5% reduction really isn't that big of a deal. But on the other hand, some patients, if they even had a smaller benefit, might think it would be worth a chance of taking a statin medication to reduce their risk of a heart attack, stroke, or death, even if that risk reduction was only 1% for them. I know this strategy may seem odd, and really most doctors right now are following a guideline called ATP3, and this set of guidelines was created by the National Cholesterol Education Program. These guidelines want patients' cholesterol numbers to be at very specific levels. Unfortunately, there's no evidence for this. It was based off assumptions, but what we do know is that the evidence does show statins can prevent heart attacks, strokes, and death. The strategy I've laid out is becoming more popular in the United States among a lot of different doctors, and other countries also use a similar method to the one that I've laid out here. I'll summarize what I just said. Cholesterol is one of many risk factors for cardiovascular disease. We can use statins to decrease the risk of heart attacks, strokes, and death. And the size of the benefit to you is based on your level of risk. Once you decide to use a statin to decrease your cardiovascular risk and risk of death, you no longer have to worry about where your cholesterol numbers are and can focus on more important things in life, such as eating right and moving your body. There's other details of the cholesterol story, but I'll leave those for another presentation. Thank you very much for listening. My website is MirochnaFamilyMedicine.com. Again, I practice at Vail Park Primary Care and Lake Porter Medical Group. And if you're looking for an appointment, you call either of the two numbers above to schedule one. Thank you.